Welcome to the Healthful Woman podcast. Today's Monday, August 23rd, 2021. Hope you've all been enjoying your summer. Hard to believe that Labor Day and the new school year are right around the corner. For today's podcast, Stephanie Melka returns to talk about the very beginning of pregnancy, basically from the time you get a positive pregnancy test until the first prenatal visit. Or, as Melka calls it, I'm pregnant, now what? Last week, Sarah Costant and I talked about the last few weeks of pregnancy, so I guess it's fitting that Melka and I are going to talk about the first few weeks. This should be a great podcast for anyone who is newly pregnant or anyone with a friend or family member who's pregnant, if they told you about it. Thanks for listening, everyone. Have a great day. See you Thursday for high-risk birth stories. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. All right, Melka, welcome back to the podcast. What's going on?
Hi, happy to be here as always.
Always happy to see you. The idea behind this podcast was yours. You wanted to do this and you said, hey, let's do the
Yes.
I'm Pregnant Now What podcast. So what inspired you to this?
So sort of the same thing that inspired the Advanced Maternal Age podcast. Like, This is something for years I've been getting questions on from family, from friends, from not friends, from like people I went to like grammar school with that just send me a message like, hey, I just found out I'm pregnant. Like, what should I do? And all sorts of variations of that.
So this podcast, like the others, just to make your life easier.
Exactly.
Here, listen to this.
This is how I'm going to hack medicine. Anytime someone asks me a question, I'm just going to send a podcast their way.
It's going to be like when you do those, like you're texting or doing online chat and with a supposed quote unquote human where you type something and you get the automated response. Anytime someone texts Melka with a question related to medicine, there'll be an automated response with a podcast attached to it.
Sometimes a blog on our website, sometimes a podcast. So there'll be crossover.
I think it's an interesting idea because, we had a podcast about what to do to prepare for pregnancy. And obviously we've had podcasts about prenatal care and pregnancy, but there is, that period of time between getting a positive pregnancy test, usually at home, again, a urine pregnancy test, and showing up to the doctor, people are like, what do I do? Like, where do I go? What do I do? Especially, obviously, if it's a first pregnancy and if people haven't thought about it too much or haven't prepared about it, which is fine. And yeah, that happens a lot. People usually call our office and they're like, I need to be seen tomorrow. Like, I have a positive pregnancy. I'm coming in. So, okay, so let's talk about this. So why is it that we don't see them tomorrow, right? Someone has a positive pregnancy test today. Why are they not coming to our office tomorrow?
So when you get your positive pregnancy test, we could do a sonogram and see absolutely nothing.
Right.
And then you're looking at, are you sending blood tests? Are you following them? Are you just waiting? So it's just logistically easier to say, come in around, 6, 7, 8-ish weeks.
Right.
Take a look. We'll see something at that time.
Right. How do we date a pregnancy when you say 6, 7, 8 weeks? Because this is confusing to people, and I think it's confusing intentionally to make us seem smarter than we are. But explain, when we say someone is 6 weeks, what does that mean?
I'm going to explain this and get it wrong because it's so convoluted.
Right.
So you're saying 6 weeks from their last menstrual period.
Right.
But you don't conceive at the last period.
Right.
You conceive 2 weeks after the period.
Right.
So when we say, when is your period, your X number of weeks, it's adding 2 weeks on to when you actually conceived.
Yeah, it is really weird. And I think the history behind this is, this is before the time of pregnancy tests, ovulation cycles, anything like that. All we knew about timing was when did a woman get her last period? And, typically women would get it about every month, plus minus. And so when someone would show up and they were pregnant, and usually they wouldn't know till, 3-4 months later because they didn't get their periods. They say, all right, when was the first day of your last period? And then they would count from there. And that's how many weeks they were at that time. But we know that you don't ovulate until 2 weeks after that day. So you can't get pregnant really until 2 weeks, give or take, after that day. So when we say 6 weeks, we mean 4 weeks from conception. And it gets really confusing for people when they have IVF, right? So they have IVF, someone comes in and puts in an embryo and says, you're 2 weeks and 5 days today. And you're like, what? Like, you put this in 2 minutes ago. But that's basically how it works. So we count from the last period. Sometimes I say we count from the life of the egg. whatever. It's always confusing to people. But again, when we say 6, 7 weeks, we mean from the period, which would be 4 or 5 weeks, again, from conception. And usually there isn't a positive pregnancy test until 4 weeks from the period or about 2 weeks from conception. So when someone calls it a positive pregnancy test, we assume they're about what we call 4 to 5 weeks. So when we say come at 6 to 7 weeks or 7 to 8 weeks, that's just a few weeks later.
Yeah.
Yeah. And this does confuse people legitimately. Why we haven't switched to like something more scientific and normal, I don't know. It's just a convention. Okay. So we don't see people really early because, again, there's really nothing we're going to see.
Mm-hmm.
I mean, we can do blood work to get an HCG and a blood test, but we're not going to see anything in ultrasound. There are some people that, again, if they have a lot of like medical issues or things that we have to take care of, or maybe adjust their medications or change, like if they know that there's a lot of stuff that has to be done and it wasn't sorted out before pregnancy, maybe we would either see them early or talk to them on the phone or do like a virtual consult or something like that. But we don't typically see them in the office for, let's say, 2, 3, or 4 weeks, give or take, from the time that they get this positive pregnancy test. Okay, so they have this period with no counseling,
right?
No nothing. So this is what we're addressing.
This is where I come in.
This is where Melka comes in and her text comes in. So what should people know at that time?
No one really likes my answer because it's usually there's not much to do differently.
Right.
I'll be like, you're young and healthy, correct? Like, I don't know all my friends' medical problems. But
Right.
I'll just be like, are you on any medications? Have you had any like big surgeries? Have you had like an ectopic pregnancy before where I think you're somebody that should go in early? And I'm like, nope, just live your life.
Right.
I mean, the big thing is exposures. Like if you've been drinking alcohol, stop. Certain dietary changes. And then that's sort of it.
And then
and the big one for me, as you know, is exercise.
Right.
It's all the people I know, like running, yoga, swimming, biking.
Right.
For the most part, continue.
Excellent. So when should someone, they get their positive pregnancy test, let's assume it's 4 weeks from their period, give or take, who should they call? Right? Who do you call in order to make an appointment? Do you call your gynecologist? Do you call an obstetrician you don't know? Do you call a high-risk specialist, a midwife? What do you do?
All of the above. I mean, if you have a gynecologist, that's usually the best place to start. GYN-only doctors won't deliver, so you'll end up needing to see an OB. So some women might choose to just go right to an OB practice.
Right.
Others will want to see someone that they know already.
Right.
You know, it's a little bit easier. They feel a little more familiar with them.
Right. So let's talk a little bit more about that. How would someone know if their doctor, right, the person they see every year for their pap smears or to get their birth control, or apparently in this case to come off their birth control, how would they know if that person does or does not take care of women during pregnancy?
Usually just asking them.
Right.
It's either on their website or just calling the office directly.
Yeah, because when we train in obstetrics and gynecology, we learn both obstetrics, which is care during pregnancy, gynecology, which is basically women's health care, and surgery related to gynecology. And the majority of people who finish that training do both gynecology and pregnancy or obstetrics, but there's some that do just one or the other. So for example, I really don't do gynecology. I just do obstetrics. And we have people in our practice who just do gynecology, and they will typically be very, forthcoming with this, say, hey, like when you get pregnant, they can see you, verify it's a pregnancy, do an ultrasound, send blood work, give you a prenatal, whatever it is that needs to be done. And then they will refer you to someone who does obstetrics. And this is something you can either ask at any gynecology visit, or like you said, call the office and say, hey, does Dr. So-and-so see patients during pregnancy? And they'll either say, oh yeah, she does, he does, they deliver here, this, or, they'll see you for the first visit and then refer you to a colleague of theirs. But that's sometimes important to know, because some people are surprised to learn that the doctor they've been seeing all this time suddenly says, oh, by the way, I don't deliver babies. I don't take care of people who are pregnant past the first trimester. So that's something if that's going to shock you, you may want to find out on the front end if that's something your doctor does. So if your doctor just does gynecology, you can either call them, and they typically will see you for the first pregnancy visit, again, to verify everything, make sure everything's healthy, and send you along to somebody else. Or if you know where you plan to go for pregnancy, you can see that person. And how does someone decide if they're going to see an obstetrician or a midwife? I'm curious how you think about this.
Midwifery typically is lower risk, healthier patients, as well as uncomplicated deliveries.
Right.
Now, clearly, you're newly pregnant. You don't know what your delivery is going to be like. But if you're somebody that's really thinking like you want a birthing center, you want like no epidural, you may gravitate more towards midwifery care.
Yeah, and I think a lot of people aren't going to be able to sort that out until they're pregnant and sometimes figure out what their risk factors are. And because not everyone knows what the risk factors are. Like someone might say, "Oh, I don't know that. Like the fact that I, had a heart transplant as a child makes me high risk. Who knew?" Right? But I mean, there are things that surprise people. And so one option is you're allowed to quote unquote shop around. You can see a midwife for your first visit, see an obstetrician the next day, and sort of see which vibe you like better, and all those things, and try to sort it out and ask them. And people usually are pretty hopefully open and honest about who they take care of and who they don't take care of, and what are their strengths and what are their weaknesses for themselves and for their practice.
Yeah, I see people early on who are asking, can I deliver at home? Can I deliver in a bathtub? Can I
Right.
deliver in a birthing center?
Right.
And like that's usually the segue of like, we're an obstetric practice. We
Right.
deliver in a hospital.
Right.
Like, yes, we can do low intervention, but not to that extent.
Right. Like you can do those things, but we can't take care
Right.
of it. We don't have bathtubs. No, but that's an important thing. And then sort of like next levels, who needs to see a high risk practice? And I think generally people would, if they know that, they may have already met with this person or spoken to their doctor. Hey, when you're pregnant, I'm going to send you this high risk practice. But again, if you're not sure, that's a question you could ask, either the midwife or the obstetrician, or make an appointment with a high risk doctor who takes care of women during pregnancy. And, sort of fortunately, when you just get pregnant, there's a lot of time to sort that out in the first trimester to figure out who's going to ultimately take care of you during pregnancy. But usually I advise people to call sort of shortly after they know they're pregnant. But again, the appointment's not going to be until 2, 3, 4 weeks from that point, mostly just to get something, on the calendar, if it's a time or date you want, if you want someone to come with you, whether it's your partner, whether it's a friend, whether it's a family member, or whether, again, for work and all these things, just to make sure that you can try to get the appointment you want.
Yeah. And that's also hard because there's very limited information we can give over the phone.
Right.
So like, one thing that we've talked about is like a VBAC. And,
Right.
I know patients will call our office and say, I want a VBAC. Can I have a VBAC with you guys? And like,
Right.
you can't have that conversation over the phone.
Right.
So yeah, that first visit, just to like be seen in person, have those questions answered really helps.
Yeah. And it'll help sort of gauge on both ends. We'll be able to ask her sort of about her last delivery, about her health history, and sort of get a sense for her whether we think it's, like in your VBAC example, whether it's safe to do it or not safe to do it, whether we think it's absolutely not going to be an option versus, yeah, it is an option. And on the flip side, the patient herself can say, okay, are these people who seem to be in favor of it? Are these people who do it? Are these people know what they're doing? Do they have a reputation? All these things, and get a sense of their attitudes for it. And the same thing again, if it doesn't seem right, then make another appointment with somebody else, and then you can always decide who you're going to follow with. And I think that that's a really important thing. You can change doctors. Obviously, when you get late in pregnancy, it becomes more difficult logistically, but certainly early in pregnancy, very, very easy to see a couple of people or a couple of types of practices and then make a decision, who am I going to follow with? I think it's a courtesy to tell all the people you saw what your plan is afterwards. Like if someone saw me for a new pregnancy visit and then they never show up again, I might assume that they went somewhere else, but I also might be worried that like, what happened to this person? Is she okay? Did she have an ectopic pregnancy and stuff? So it's nice to call and say, hey, I ultimately went with another practice. No one takes that personally. We just say, okay, and we close out your pregnancy. And if you need any of the blood work we sent over, we'll send it. So that's a nice courtesy. And then what about for people picking like a group practice versus a solo practice? Is it the same thing where they should just, meet with that person or that group and figure it out? Or there's things that they might know on the front end to help guide them?
I think on the early on, some people might feel very strongly of, I want to know exactly who is going to deliver me. And they'll end up either in a solo practice or maybe in like a group of 2 or 3. Do you care if it's only females, if there's male doctors? And I think it kind of all comes into play together.
Yeah.
My understanding, the big downside of a solo practice is if you could have a scheduled appointment, and then if that doctor is doing a delivery, your appointment can get moved at the last minute or canceled. And that's a barrier to some people.
Right. Yeah. I think it's probably a totally separate podcast on the, advantages and disadvantages of a group versus a solo practice. And there's advantages and disadvantages to both, but it's something to think about. Like you said, when you're signing up for a practice, does it matter to me if they're all women or not? And if it matters, you may just want to find practices that are all women. And nowadays it's all on the website. It's very easy to figure this out. Yeah.
It's
Geographically,
still not,
insurance.
Though.
Really?
Me, every couple weeks I'll get somebody that'll come in and will say like, I only want female doctors.
Mm-hmm.
And I'll be like, I'm sorry. Like we can't do that. Like,
right.
Like of our 9 or 10 delivering doctors, like half are men. We can do what we can to an extent, but things happen at all times of day or night. And
right.
if that's a deal breaker, like you said, we don't get offended.
Yeah.
Like people end up going elsewhere.
Yeah, no, it definitely, those things are important to people. And everyone's got their own thing that's important to them. For some people, it's geography. I want to be within X miles from the hospital. For other people, it's I want to be 1,000% certain that everything's on my insurance. And other people don't care. I mean, there's really a lot of variables that go into it.
Some people choose based on what hospital they want to deliver at.
Right.
Whether it's a positive or a negative.
Right.
Someone may deliver at a certain hospital and then they tell their friends, like, it was an awful experience. Like, the rooms were ugly or this or that, and don't go there.
Right.
And then other people will rave about the hospital, and then people will choose based on that.
Right. Okay. So someone is pregnant. They're making their appointment. You're not going to get a lot of information from the people who pick up the phones and schedule your appointment. Maybe the practice has a website that'll give you some information about, things to do, things not to do, but just general advice. So prenatal vitamins. So someone's pregnant and they're not already on one. And they're like, oh my God, did I hurt the baby? Is it, is there a problem? What would you tell them?
Very, very rare that there's a problem.
Right.
But worth starting on one when you know.
Yeah.
Mainly the folic acid component.
Yeah. And that's an important point because, really the only part of the prenatal that's potentially important early in pregnancy is the folic acid. So a lot of people, when they get pregnant, they're nauseous pretty quickly. And prenatals tend to be pretty big and they have a hard time swallowing them. So if you either pick up a prenatal or a multivitamin or whatever, and it's not working for you, just take folic acid. Those tend to be very, very small pills, usually easy to tolerate. The recommended dose is 400 micrograms, which is also 0.4 milligrams in case it's written like that. A lot of times people will take double that, take 800 or 0.8. Typical prenatal has either that, or sometimes close to 1 milligram or 1,000. But that's one of the things that probably should be taken. All the other parts of the vitamin, yeah, it's fine if you're on it and it's nice, but it could wait if needed. It's not a big deal if you're on it or not on it. And again, most people who aren't on folic acid, their babies will be fine, but it does lower the risk of certain birth defects. So it's good to be on it either before you get pregnant or right after you get pregnant.
There are some foods fortified with folic acid or folate nowadays. So a lot of people do get it somewhat in their diet. But yeah, ideally start it a few months before you try to get pregnant or once you find out.
Right. And this also, a lot of people call up and say, I need you to prescribe me.
I don't like prescription prenatal vitamins. I think they're expensive. I mean, they're really expensive. They could be like $1 a day for something that you could get 4 times cheaper store brand.
Yeah.
There's a lot out there of clean pharmaceuticals and that the CVS brand has too many additives and this other one doesn't, but they all give you the basic stuff that you need.
Yeah. I mean, I think a lot of it needs to be personalized. I mean, ultimately, for the vast majority of people, any prenatal that has folic acid, it's going to be fine. I mean, there's
some that are smaller.
Yeah.
There's some that are chewable.
Yep.
There's some that have DHA or don't have DHA.
Right.
And then in the DHA family, there's some that's plant-based, which is a little more expensive than the fish-based. But the fish-based ones taste like fish, or people are like, I get fish burps after I eat it.
Right.
So yeah, if you're taking a prenatal and it's making you puke your brains out 20 minutes afterwards, switch. Find another one. If you can't swallow pills, take a chewable one or take one of the smaller ones. Yeah.
I mean, there's a lot of prenatals that are marketed and some of them have their own, I don't want to say gimmick. There are gimmicks in a bad way, but I don't mean this in a bad way. For example, there's one that's, designed to also include more things that'll help with nausea in pregnancy. And, okay, like maybe that's going to help more than a different vitamin. There's other ways to do it, obviously. And some of them, again, their gimmick is that they're chewable, which is nice. And some of them, have more of this and less of this and, the size, all those things. But ultimately, particularly if in your own insurance plan, it's going to be expensive. It's rarely needed that your prescription is, prenatal is prescription. Very, very unusual. We would say, oh no, you need to be on the prescription brand, prescription strength. For some people, their health plans are such that the prescription prenatals are like dirt cheap and great, God bless, that's fine on our end. But usually that's not the case. And it's very rare that it matters on our end. People are usually shocked when they say, which prenatal should I take? And be like, I don't care, really just depends on the situation. There are some things about, again, tailoring, what you need per trimester, but for the most people, if you eat a well-balanced diet, as long as you're getting that folic acid, you should be okay. Calcium's another thing, but hard to get that in prenatal. Some people need supplements and we give it to them. But from the point of the positive pregnancy test until the first visit, folic acid is typically all you should be getting. Okay, so you mentioned alcohol.
Yes.
This is a big one. I got pregnant. I didn't know I was pregnant for a week. I've been drinking. I've been partying. I've been going out. By the way, not because I don't do any of these things. I'm like the biggest loser you ever met in your life. But maybe someone has more of a social life than this podcast host does. Should they be worried?
I think it's a normal reaction to be worried, but medically, no.
Right. And why is that?
So early on, it's if there's any kind of exposure, it's thought to be what's called all or nothing, meaning if there's harm done, the pregnancy will not implant or will miscarry very early.
Right.
But it's really unlikely to get significant birth defects from social alcohol consumption or even more than just casual social consumption early on until you get that positive test.
Yeah. And I think there's really two important points you said. The first is that typically the volume that people consume is not going to be dangerous at any point in pregnancy, meaning a lot of people call say, oh my God, I had a drink last week, or I went out to dinner and had 2 drinks at dinner. That type of volume, sure, we discourage alcohol during pregnancy, but the volumes we're talking about really probably never cause problems at any point in pregnancy. But even someone who says, oh man, like I was at the bachelorette party the other night and we got,
I've heard some of those,
got trashed, and then suddenly I'm pregnant. Is there a problem? If you think about it, when there's something that could cause a problem in a developing, baby, fetus, embryo, it's only going to affect that organ when it's developing. So for alcohol, we worry more about the brain, right? From the point you get pregnant, going backwards, there is no fetal brain. It's a sperm and an egg. That's it. And they come together. So it's a clump of cells. Even for several weeks, there's no brain developing. So it can't affect the brain. Alcohol doesn't last in your system, right? Once you're, when you're hungover, it's out of your system essentially. So unless someone really didn't know they were pregnant and they're like 10 weeks pregnant, 11 weeks pregnant, somewhere in that point, and they had a ton of alcohol, all right, that puts them at risk. Now, it doesn't mean it'll happen. Most of those people, it still won't happen. But those are the people who there is a concern. But if you're like 7, 6, 5 weeks in that range, really there's no concern. If there was something so crazy went into your system, like you said, you're probably going to either not get pregnant at all or you're going to miscarry early, but it should not have an effect. And that's true with most things that people are concerned about. So again, rarely is there an issue with any drinking that was done before the pregnancy test. That's pretty much zero. And even afterwards, if it's in the short time afterwards, it should not be an issue. Okay, so food. So now that someone's pregnant, are there any foods they need to avoid between now and their first visit?
Probably not. The things that are, concerning are the things where you could physically get ill from eating.
Right.
So like raw and undercooked things, like a raw egg could have salmonella.
Right.
Things where you could get exposed to listeria.
Right.
So that's like deli meat, unpasteurized dairy, and then mercury consumption, which is large fish.
Predators.
Yes. Shark, swordfish, mackerel, that type of stuff.
Yeah.
And even then, those exposures early in pregnancy, like, again, the mercury is brain development. And the thought is, like, if you're eating a lot of it, that might not leave your system right away.
Yeah, mercury sticks around a long time. So I guess if someone is truly on a high mercury diet, right, that's probably the time to cut back when you know you're pregnant, just because this lasts in your system a while. You're going to want to give your body time to sort of get rid of it as best as possible. So if you're a big shark eater, maybe when you get pregnant, you should back off. The truth is that's something you probably should back off before you get pregnant if you can, because it really lasts in your system for a long time. But most people, even if they're having that, are not mercury toxic or anything like that. Tuna is the one a lot of people ask about. There's not a lot of mercury in tuna. So if you're eating it in the range of once a week, maybe twice a week, it's probably fine either way. And I let, people do it the whole pregnancy. So I certainly wouldn't tell them to stop. You mentioned exercise again. People are very worried that from the point they get pregnant, so they see the doctor, if they exercise, they're going to miscarry. True or false?
False.
False. Capital F. False.
Capital FALSE.
Yeah.
False.
Yeah. Will not cause a miscarriage.
Look, there are pregnancies that are going to miscarry anyway, no matter what someone does.
Yeah.
But exercise will not. There's nothing physical, like people will say, like, can I run? But isn't running going to shake the baby out?
Right.
No, it's not.
Right.
Like, no.
It's important for people to know that from the point of a positive pregnancy test, there's a very high chance of miscarriage. It's kind of a bummer, and it's kind of a downer to talk about this, but that's just how nature is. And when people quote like the percentage of miscarriages and, you look it up in this, you have to keep in mind, it depends what is your starting point, right? So the likelihood of miscarrying once there's an ultrasound with a heartbeat is typically some number under 10%, right? And based on how old you are and the miscarriages you've had, okay, you can modify that. But before that point, it's much higher, right? So someone gets a positive pregnancy test, it could be as high as 40%, 50% chance of, getting your period a week later. We call that like a chemical pregnancy, meaning the only evidence, quote unquote, you were pregnant was either a blood test or a urine test, never saw anything in ultrasound. And so this isn't meant to like depress people, but it's people should know that. So just that expectations are realistic. And also B, that even though it's very sad to lose a pregnancy very early, people shouldn't think it's uncommon or that it means there's something wrong with you. Almost never is that the case. But also just to understand why there's so much out there. Like someone could say, oh, I had a positive pregnancy test, then I went for a run, and 3 days later I got my period. It caused it. And yes, it seems that way temporarily, but if you look at the people who didn't run, the same percentage of people had bleeding 3 days later and lost their pregnancy, so to speak. And when we look at these things in bigger studies, that's why we have such a high level of confidence that those things do not cause the miscarriage, right? If your chance is 40% miscarriage, 40% whether you run or whether you lie down in an oxygen tent, it doesn't make a difference.
And I've seen it with everything.
Yeah.
Getting a massage, getting a pedicure, getting on an airplane, swimming, carrying their toddler, everything. There's someone that says, I did that, and then a few days later, miscarried.
Right. It's hard to make your brain not see that connection because it seems so obvious. But again, when you look at groups of people, it's no more likely in the people who do all those things versus those who don't. The reason people miscarry from early pregnancies is almost always from day one, the embryo is genetically abnormal. And there's no control over that. Obviously, it's already been determined the second the sperm and the egg meet. And so clearly what you're going to do is not going to affect the genetics one way or another.
The big thing with exercise I will just add is, the same thing I tell people in pregnancy, like this is not the time to be pushing yourself like crazy.
Right.
I was super early pregnant and I knew it because I went out for a run and I was like, I feel miserable.
Right.
And I couldn't do it.
Yeah.
And I'll tell people like, yes, you can keep doing what you're doing, but don't go crazy, like feeling you have to be hitting the same level.
Right. It's very difficult to do. The pregnancy.
For some people. Other people are totally fine.
Yeah. But just like symptoms, some people are like puking all day and some people don't throw up at all. And the same thing with being, fatigued or exercise intolerance, all these things. It's different people experience pregnancy differently. We don't really understand why that is so much. It could even be the same person, different pregnancies. Some people have like, this pregnancy I was nauseous, this pregnancy I wasn't. And we really don't understand that so well, but it's definitely the case. So getting back, sex is the same thing. It may cause some spotting. The cervix gets a little friable, gets a little more sensitive. But it certainly will not cause a miscarriage. It just doesn't work like that.
Some people notice cramping as well.
Mm-hmm. Yeah.
But again, not going to cause a miscarriage.
Right. How about, now I'm pregnant, so I have to sleep on my left side, right?
Never.
Right. So why is that?
You have a blood vessel called the vena cava that brings blood from your legs up to your heart. Later in pregnancy, as the uterus gets bigger, if you lie completely flat, the uterus will compress it a little bit. You don't suffocate yourself. You don't suffocate the baby. But because that blood vessel is a little bit to the right of the spine, people say you should sleep leaning towards your left or on your left side,
right,
to move the uterus off of it. So early on, that is absolutely not a factor.
Right.
Any sleeping position is fine.
Yeah. Even late in pregnancy, I'm fine with any sleeping position. All that stuff was from like data for women in labor.
Yeah.
Like while they're laboring, we'll sometimes notice if they're flat on their back, you can tell that their blood pressure is a little different. Maybe the baby's heart rate's a little different, and we move them to left or right side. Doesn't matter what side, and it improves. But there's a lot of evidence that it makes no difference. And particularly early in pregnancy, sleep any way you want.
Yes.
God bless.
I'll even see people.
If you can sleep.
You can sleep flat on your stomach.
Yeah.
You're not going to crush the baby. You
Right.
can sleep on your back, either side.
Yeah.
Even closer to term,
Yeah.
a lot of women wake up flat on their back and they're
Right.
like, oh my God, what did I do?
Right.
You did not do anything.
Right.
It's not an ideal position.
Right.
I do tell people maybe like 20 weeks, like if you really are like a back or stomach sleeper, like start changing sleep positions a little early. But yeah, really early on, nothing different.
And then what about medications people are on? How do they know if they're safe to continue in pregnancy? Let's start with pills. We'll get to creams and lotions and stuff after.
Probably have to ask whatever doctor prescribed them.
Yeah.
Generally, it's not a good idea to stop pills without talking to your doctor.
Yeah.
And it could be something simple like a thyroid pill. Like any endocrinologist should be able to say like, yes, you can continue this.
Right.
We have women that are diabetic, that have high blood pressure, that are on pills that are not
Right.
ideal to take during pregnancy. And again, their physicians can tell them like, okay, stop this, but start something else.
Yeah. And there's leeway with this, meaning the pills that are like red warning, black label, skull and crossbone danger, everyone who's prescribing them will say to a woman, are you pregnant? Might you be pregnant? Can you get pregnant? Don't get pregnant. Like they're all over it. They're like, please have 6 forms of birth control and sign this form. And you'll know like
that's
this
like
is
Accutane.
danger. Yeah.
Like you take Accutane, you need a contract with your dermatologist
Right.
that you're on 2 forms of birth control.
Right. It's like stranger danger. I mean, they're all over it. So yeah.
I had someone once that like couldn't use 2 forms. Like she couldn't take hormone, like estrogen. She couldn't have an IUD.
Right.
This, that. I had to like write a letter saying like, I have counseled this woman on contraception.
Right. Right. And those medications. So if you're on one of those, you'll typically know about it. The other ones are usually ones that are probably okay. But even if it was something we'd prefer you switch, again, from the time you get pregnant, you got weeks typically till you would have to switch it. Like if you're on a blood pressure medicine, we'd prefer you be on another one. You got a couple of weeks, all these things. So it's not something that someone, if you need a pill for your own well-being, medical, mental health, whatever it is, don't stop them. Like call whoever prescribed them or call your OBGYN, like try to get that sorted out. And you do have some time, but stopping them, I would say more often than not is going to cause more harm than good. And so it's probably not a great idea to do that. And if you're someone who's really concerned about these things, obviously those are great questions to ask before you get pregnant. Like, hey, when I get pregnant, do I need to stop this or switch or something? But we're talking about for the people who have not made those plans. Okay, we love you too. It's all good. And what about things like, we get asked a lot about skin products, right? Whether it's prescribed or over the counter or whatever it is, do people need to stop those?
For the most part, no.
Right.
The big one that people will stop are the retinoids.
Right.
You know, tretinoin is the big one that's prescribed because of that thought of it being absorbed into the skin and converted into X, Y, and Z.
If you ate it, it'd be a problem.
Correct.
Right.
But you're not going to get those levels in absorption. But people still, to play it safe, will say don't use it during pregnancy.
Right. But the rest are fine, basically. Yeah. Makeup, over-the-counter stuff. Yeah. I mean, it's all good.
Yeah.
So that, okay. So
even,
that's,
like benzoyl peroxide, whether it's the cream or the wash, like I tell people, yes, you could stay on them, which sometimes is upsetting to women because they're like, my dermatologist said I should stop it.
Yeah.
And I'll like explain, you know.
Yeah. Take it up with your dermatologist. I'd sometimes say have them call me.
Yeah.
And some dermatologists are like, oh, it's okay with you? I'm like, yeah, it's fine. She's like, okay, great. And some of them are like, you know what? I hear you, but I'm not comfortable with it. Fine. Like, what are you going to do? Doctors disagree sometimes.
Yeah.
This is like this is the world we have to navigate.
Yeah.
We can't all agree.
This is another area you look online. If you look up like skin lotions or creams in pregnancy, like huge rabbit hole of like clean beauty and preservatives and all this stuff. And
my beauty's clean beauty. This is all natural. I've got no makeup on, Melka. This face you see is just, the face I was given. And then what about like cleaning products? Oh my God, they were painting my house when I got pregnant. I walked by a construction site. All these things.
All fine.
Yeah.
You're getting so little exposure. A lot of the chemicals that smell.
Right.
You're not inhaling high quantities of the concerning chemicals.
Right. You probably pass out.
Correct.
Yeah. I'd say if it's enough to harm the baby from that type of exposure, it would harm you. It would harm you first. You would be very, very ill. People get like carbon monoxide. Like, do I have an issue? Like, if you're like okay in breathing, it's not going to do anything. You're gonna be okay. The one thing people ask about, which I think there's some evidence to support, is stopping to use like hot tubs in the first trimester when they get pregnant. It's not great data, meaning it could be total bogus, but there's some data that women who use hot tubs or go in hot tubs, there's a slightly higher risk of miscarriage. And so a lot of people tell women to avoid it, like from their pregnancy tests or first trimester. Again, we're not certain it's the case, but they're probably avoidable for most people. And so why not?
I've heard of the increased maternal body temperature and increased neural tube defects.
Right.
So avoiding the hot tub because of that.
Yeah.
And that is not a bathtub.
Correct.
A lot of people ask this. And I'm like, sitting submerged in a jacuzzi is not affecting your body the same as sitting in your bathtub even with really hot water. Like,
right.
You're not getting that same level.
Right. And and also the bathtub you're in is not heated, meaning it cools off. So once you you get in, your body temperature and the water temperature start to equilibrate. So yours won't go up. Whereas a jacuzzi, it's continuously heated. So it's like boiling, so to speak.
Yeah. I do tell people, probably worth it to avoid hot yoga because you are in a hot room for a long period of time. And with exercise, it's just so unpredictable how your body's going to respond, especially if you're doing a lot of inversions.
Right.
But again, like I have, patients that are experienced yogis that are like, I can hydrate. I know my body. I've done this before.
When should people expect to start having symptoms of pregnancy?
Yes. At any time.
Yeah.
Usually not at the first pregnancy test, which I think is why a lot of women are surprised when they get a positive test because they're like, I feel fine. And sometimes it's not until 6-7 weeks that they start really feeling fatigued or nauseous.
Nausea is definitely a sign of pregnancy, but it tends to come actually a little bit after things like feeling tired or what we call fatigue. Breast tenderness is usually a very early sign because that's just like from the progesterone. Sometimes people feel like they're peeing a lot more than they were. Those are a lot of early signs of pregnancy. And again, some people have none of these symptoms. Some people have a lot of these symptoms. It's not that well correlated with how quote unquote good the pregnancy is. I mean, sort of when someone has a lot of symptoms, we say, oh, it's positive because it's a good pregnancy. It's just mostly to make people feel better, but it's not always correlated that well. People ask me all the time, when should I tell that I'm pregnant? When should I tell people? Do you get that question a lot?
Yes.
Yeah, like all the time.
Which is interesting because, again, these are like people that like I know socially and I'm finding out before like their parents sometimes or like their, closer friends. I usually start with, how far along are you in the pregnancy and like what's the miscarriage risk? And are you okay with these people knowing that you had a miscarriage? What I usually say to people is like positive test first visit. You're probably only telling a few like really close family and friends. Mm-hmm. And then maybe by 12 weeks, you've done genetic testing, things are growing well, you're starting to tell like closer family and friends. And then 16, 20-week anatomy scans or the Facebook pictures or like the Instagram announcement when like, hey, now the world knows.
Yeah, it's like this whole like ritual that people go through it's just, like you said, it's really just how some people are very comfortable with everyone knowing what's going on in their life. great. Just tell everyone immediately. Like if you would prefer everybody know that you got pregnant, had a miscarriage, again, if you miscarried, had a miscarriage, so that they understand why you're going through a tough time, why you may be in a bad mood, or why you didn't show up for this, or why you're not drinking at your friend's party, or whatever it is. If your life is like an open book with your friends and family, tell them immediately, like whatever, it's your business. Like there's nothing on our end. We don't care if you tell people. And if you're more the type person, I'd rather not people not know my business. I'd rather if I had a miscarriage, I just want to keep it real tight in my family and that's it. Then yeah, you're not going to tell people until you're highly confident that's not going to happen sometime after 12 weeks. But again, from our end, we're fine with anything.
Yes.
Like it's, God bless, whatever makes people, go through this world more comfortably, that's fine with us. But I do get asked it all the time. Like, when should I tell? It's like, when do you want to tell? You told me, yeah, I'm happy to know.
One of our next episodes can be like, how do I fake drink at my blank?
Feed it to the dog. Yeah.
Did that at my cousin's wedding.
You fake drank?
Yes. People do so many different things. You can have the same glass as what your partner's drinking and you just carry it around.
Mm-hmm.
You can just get soda water with a splash of cranberry juice and a lime in it and make it look like alcohol. There's a whole thing on this, because if a reproductive age woman who usually drinks is not drinking, everyone will assume they are pregnant.
Right.
Yes.
Yeah, there's so many
There's
reasons,
many listeners out there right now that are nodding their heads.
Yeah, there's so many reasons why that doesn't apply to me. Not reproductive age. I'm not a woman. I don't drink. All right. All the above. Okay. So overall takeaway from the point of the positive pregnancy test, there's not a ton to do. There's not a ton not to do. Maybe pick up a folic acid if you're not on it already, or a prenatal, whatever, something that has folic acid. Don't do anything crazy dangerous. Figure out, what appointment you're going to make and with whom. And again, not to be a downer, but it might happen. It will miscarry, and it does not mean it's because of anything you did. In fact, it's not because of anything you did. And then again, for some people, they find that comforting to know that it's out of their hands. For other people, they find it horrifying that it's out of their hands, but that's just sort of the reality of it. But again, for the vast majority of people who call, we're going to see them a few weeks later. Everything's going to be fine. And then we're going to be rolling.
Yeah.
Amazing. I'm pregnant. Now what?
Listen to this podcast. Now what?
Thanks for coming on, Melka.
Thanks for having me.
Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.